Hello, good evening. Welcome, everybody. I'm Dr. Kirsten Gustafson, and I'm the medical lead of the Menopause and Midlife Health Program at BC Women's Hospital. Today, I'm presenting from the traditional, ancestral, and unceded territories of the Coast Salish people, including the Katzie, Kwantlen, and Semiahmoo First Nations. And I'd like to welcome all of our presenters, participants, and guests from all across the province. Tonight, firstly, I'd like to recognize the Pacific Blue Cross, who partnered with the BC Women's Health Foundation to sponsor this webinar series, and also acknowledge the contributions of the BC Women's Hospital and the Women's Health Research Institute. Tonight's the third in our series on the topic of menopause. And our first webinar, Menopause 101, and our second one, Dr. Lori Brado's webinar on menopause, mood, and your brain, can both be found on the BC Women's website. We're going to continue to present webinars every 2 months, covering all the most important topics in midlife health. For tonight's presentation, I am happy to introduce our speaker, Dr. Kelsey Mills, who's going to talk to you about the genital urinary syndrome of menopause. Dr. Mills obtained her honors degree from Mount Allison University and her medical degree and residency in obstetrics and gynecology at the University of Toronto. She's completed a fellowship in mature women's health at Mount Sinai Hospital in Toronto. She got a master's degree in science and health science education at McMaster University. Master's of Science in Health Education at McMaster University. Fix that. Dr. Mills has been a North American Menopause Society certified menopause practitioner since 2013, and she's previously won the Sigma Young Canadians Menopause Scholar Award, also the NAMS and TIVA Women's Health Resident Excellence Award, and the NAMS New Investigator Award. So she's very, very accomplished, but I haven't finished yet. She also serves on the board of the Menopause Foundation of Canada and the board of the Canadian Menopause Society. She's a member of the Society of Obstetrician and Gynecologists of Canada. In addition to her menopause practice, she also has a full clinical practice as an obstetrician gynecologist in Victoria, BC. She's an invited speaker at provincial, national, and international conferences. She's also a clinical associate professor at the University of British Columbia and an affiliate associate professor at the University of Victoria. We're thrilled to have Dr. Mills here with us tonight. And I'd like to thank everyone who submitted questions in advance. We'll aim to answer as many of your questions as possible during the presentation tonight. You're also welcome to leave questions in the chat, and we'll aim to address them at the end of the presentation as follows. We do appreciate all your input and questions, and even if we don't answer your question, we will be using your input to help guide future presentations. I also want to note that we have included some pictures of vulvas in this presentation, so don't be surprised when you see a vulva. So without further delay, I'm going to introduce Dr. Mills, who's going to present tonight on genital urinary aging and the genital urinary syndrome of menopause. Thanks, Dr. Mills.
Thank you so much, Dr. Gustafson, and thank you to the BC Women's Hospital and the Foundation for inviting me to give this talk to the public. I think it's amazing, the work that's being done just to empower and educate the general population. And I'm thrilled to be here on a topic that I think is really under-discussed and is critical to healthy living as we age. I'd like to begin by just acknowledging that I'm coming to you today from Victoria, British Columbia on Vancouver Island. And I want to recognize the traditional and unceded territories of the Lekwungen and Wasanich peoples, as well as the Songhees and Esquimalt First Nations, whose lands and waters have been stewarded since time immemorial by these people. I also just want to make a gender acknowledgement. You're going to hear me today use terms women or woman, and this reflects the historical view from scientific literature, also for simplicity of language. But of course, I want to acknowledge that gender is a spectrum, and I wish to be inclusive. And if there are people listening today who find themselves somewhere on the gender rainbow and want to ask, trans health specific questions about menopause, I'm thrilled to answer those as well. These are my disclosures. I did not receive any pharmaceutical funding for the presentation, and I've had full editorial control over the presentation. In terms of mitigating bias, I'm going to use generic names of medications today, and I will let you know if I make a recommendation that's off-label as per Health Canada, but I don't think I'll be doing that. So what are we going to talk about today? It's such a great topic. It's such an important topic, and I am so encouraged to see that there are so many people listening in. First, I'm going to describe the changes that occur to the bladder, vulva, and vagina with aging and with changes in hormones. I'm also going to explore with you the available treatment options because I really want to empower and educate the people on this who are listening along. Some of you may notice that you have symptoms. It can be a tricky topic to raise with a healthcare provider. And I really want you to help you understand that if you are symptomatic, there are so many things that can be done to help. And then I want to talk about ways that you might be able to advocate for your health with a healthcare provider. Because as I mentioned, this is a tricky topic for some people. It can be difficult. Some people might find it embarrassing to talk about vulvar or bladder symptoms. Some people may meet resistance when they go to talk to their healthcare providers. So I really just want to chat about that, answer your questions directly, and really arm you for better health.
Thank you so much, Dr. Mills. So, the term genital urinary syndrome of menopause is quite a mouthful. I think it was coined about 10 years ago to capture, all the things that happen with women at midlife. And I think, still some practitioners aren't using that language. So can you tell us a little bit? Like, I think our viewers want to know, like, what does that actually mean and what does it include and what's not included? We'd love to hear a little bit about that big phrase, GSM.
Yeah, it's a great question, Dr. Gustafson. And really, when we talk about GSM, we're talking about a comprehensive term that collects a constellation of symptoms. So it used to be that we would just talk about vulvovaginal atrophy or vaginal dryness as one entity that we were going to talk about and treat. Then we were maybe going to talk about people who get bladder infections over and over as one thing that we were going to treat with antibiotics separately over here. And then we started to understand that genitourinary syndrome of menopause, first of all, is a nicer term than calling people's tissues atrophic. There were studies that showed that people didn't want to have their bodies referred to as atrophic. They didn't feel good about that term. And it also wasn't a really accurate or descriptive term. So now we have sort of this more overarching term that's talking about a constellation of symptoms or signs that often we can see on physical exam that are happening because of a decrease in estrogen, sometimes a decrease in testosterone, that are causing changes to the vulva, including the labia, the clitoral area, the introitus or the opening to the vagina, the urethra, and the bladder. So it's not just one thing in isolation. And there are lots of symptoms that are associated with this. And you'll see through the slides, I've sort of broken it into genital symptoms, sexual symptoms, and bladder symptoms. In terms of genital symptoms, a lot of people historically have really focused on the dryness that comes with this, where people will gradually over time start to feel dry. Sometimes it has nothing to do with intercourse. People can feel dry even just sitting, walking, wearing underwear. They can just notice sensation. Certain people can find irritation, burning, or itching of the vulvar tissues or vaginal tissues. There can be an increase in discharge and change in the bacteria that live in the vagina as estrogen levels fall off. Some of the good bacteria can be replaced with other kinds of bacteria. And some people can get pain. And I've definitely had people come into my practice because I've met them in the emergency department where they present with significant pain from GSM. In terms of sexual symptoms, Certainly, people often talk about pain with intercourse. That could be with a partner, that could be with a toy, but or that things are just changing. A lot of people with GSM will say it feels like there's a blockage or a wall. And things start to get very narrow sometimes on sensation, and that can be associated with GSM. Lubrication goes down. Some people might start noting bleeding or even little tears or fissures after intercourse or penetration. A lot of our patients talk to us about decreased arousal, that they feel like their sex drive is becoming lower. And some patients have progressive difficulty with orgasm or say that the strength and duration of the orgasm is a lot less than what they've previously experienced. And then we can have bladder or urinary symptoms as well. Dysuria means when it burns or is uncomfortable to avoid. Recurrent urinary tract infection is really important for us to manage because this can lead to hospitalization and major infection or sepsis. And Dr. Gustafson and I have both met patients through the emergency department who are, having to rely on really big gun intravenous antibiotics to treat their infections when really what's at play is managing the hormone milieu around the bladder, and we can really make a big difference with that. Urinary frequency means feeling like you have to pee all the time, and urgency means running to the bathroom. And then there can be incontinence as well, which is loss of control of the bladder, or sometimes bleeding with wiping after urination. And that can be if the bladder neck or the urethra is starting to have signs from this lower estrogen state as well.
So Dr. Mills, I've got a participant question, and the participant says, I'm in perimenopause. So, how likely is this to happen to me? And when can I expect this to happen if it's gonna happen to me? And I feel for you because knowing all this could be in the future, that's a lot to worry about. What would you say to her?
Yeah, and it's true that listening to this as somebody who may not be experiencing it yet might be a little bit unnerving, but I think we all agree that knowledge is power, and being able to look for signs in advance is really important. So, when we're thinking about when this might occur in the sort of age spectrum, we definitely see that the average age of menopause is around 51 or 52 in Canadian people. And that people can start to experience hot flashes and night sweats as one of the first symptoms of their perimenopausal transition. And then the GSM symptoms, the vasomotor symptoms often get better on their own, but the GSM symptoms will continue on until the end of somebody's life. And so, what's interesting is we're starting to recognize these symptoms perhaps in people that are younger and younger because of more education. Historically, we've sort of seen these in people in their 60s and 70s starting to come in to talk to us. And now I'm talking to people in my practice in their 40s and asking them, have you noticed any changes in lubrication? Is penetration comfortable? Have you noticed any dryness? And I really encourage people to think about symptoms earlier because, as you're going to hear, it can be very difficult and in some cases not possible to help things go back to the way they were previously. But once people start to have these symptoms, then oftentimes we're talking about treating these symptoms and treating GSM forever. Just like once you're diagnosed with a blood pressure issue, you would be recommended to be on a blood pressure medication for the remainder of your life. And it's not a trivial topic. And I think that's why I'm so thrilled to see so many people here to listen to this presentation. This is not a rare health condition that people aren't going to come across. This is going to happen to a huge proportion of the population. We have a lot of Canadian people identifying as female. We have a lot of Canadian people who are over the age of 50 who might start to notice symptoms. Some statistics in Canada say half of women will be affected by this. There are other statistics from other studies in other countries which say 70, 80% of people, when they live long enough, will start to experience these symptoms. So it's really important that we're thinking about these and being able to raise it with our healthcare providers.
So Dr. Mills, we know that this is really common, and we know it's affecting a lot of women. And you and I know about the Viva study that really said that a large portion, if not the majority, of Canadian women weren't getting treatment for these symptoms. Do you want to talk about what we can do to maybe address that, or how we can, close that gap?
Yeah, I think it's a great question. And there are several reasons why people aren't getting help. So the first is that symptoms around the vulva, vagina, bladder, not everybody is completely comfortable talking about these. Sometimes it's difficult to find the right words to use. Some people are worried that they're going to have judgment if they take these concerns to a healthcare provider. So that can be a stumbling block for people for sure. A lot of people I meet say, well, I just thought it was normal that I couldn't control my bladder anymore. I just thought it was normal that intercourse hurt. And so we had to stop indefinitely. A lot of people think that some of these issues are just happen to everybody as they age. And probably most commonly, people think that there isn't anything that can help. And a lot of people are not aware of all the different treatment options. And the study that Dr. Gustafson referred to will come to, but so many women studied in that and other studies really weren't aware, which is why these public education campaigns are so important. Finally, we don't have all healthcare providers on board to proactively ask patients about their symptoms. And, there's a great tool that we always encourage primary care and other people doing menopause work to look at called the Menopause Quick Six. And it's a series of 6 questions that we really encourage healthcare providers to screen their patients to be proactive. Don't wait until your patient, hesitantly brings this up to you, but really proactively ask. And having any sexual concerns or concerns with the vulva, vagina, bladder, those are 2 of the questions of the quick 6 of the important menopause questions to ask. So this is the study that Dr. Gustafson was referring to. These were women that were sampled across Canada, but there are also data from other countries that can look pretty similar, in which we're only finding 1 in 4, 1 in 5 Canadian women who had symptoms were even looking for treatment or looking for help. A third of Canadian women had never seen a healthcare provider for treatment. 60% of women who had symptoms said their doctor or nurse practitioner had never raised this question or asked them about it. And half of the people in this survey were completely unaware of any treatment options. So these are challenging statistics to see. But that's why, again, public health campaigns like this, where we can talk to British Columbian women and the people who are in their lives, it's really important for us to get large scale messaging across. So I want to talk a little bit about what's actually happening to the body when somebody is going through genitourinary syndrome of menopause. And we, are aware that as people go through menopause, their estrogen levels go down because the ovaries aren't working well anymore. So when the ovaries aren't working well anymore and there are lower levels of estrogen, we can see tissue changes. We can see loss of tissue, loss of collagen, which is a part of protein in our tissues that allows for stretch. We can see loss of fat, decreased blood flow, decreased lubrication and secretions in the vagina, and atrophy or thinning of the urethra, which is the bladder neck, and smooth muscle in all of this area. That can result in the vagina becoming less elastic or stretchy. We can see fewer vaginal folds. The vagina can actually shorten in length as well as narrow side to side. and the tissue can become thin and dry. Because of these things, we can see bleeding or pain or sensation of a blockage, or people who say it's just too painful to even have penetrative intercourse. We can see that the bladder neck shortens and the tissue thins, and that the muscle around the bladder necks doesn't work as well. And so we can see more leaking, dribbling, people who are having difficulty with their bladder. And of course, lots of really cool work being done at the University of British Columbia about the bacterial colonies that live in the vagina and on the vulva. But we see that the bacteria starts to get altered too, which can be associated with increased infections and discharge. So a lot can be happening to our bodies as people are aging and going through this process.
Thanks, Dr. Mills. So I think you're gonna answer my next question, but one of the participants is wondering, so if I tell my doctor I'm having these symptoms, like what's gonna happen next? Like what's the next steps and how will they know what's happening and what's causing my symptoms?
It's a great question, and it's probably a good time to give a heads up that we might be showing some vulva photos soon. So if you have anybody who doesn't want to view these, there was your advanced warning. The first thing I say is I applaud you for bringing up your symptoms with your healthcare provider. And in my opinion, what should happen next is that that provider should meet with you, ask questions about your symptoms. Examination is really important, and I'm going to make this point in a couple of slides with the photos, but we should be looking on the outside and doing an exam of the vulvar skin to make sure we're not missing something else that could cause pain or itching or sexual issues. Oftentimes, we're going to recommend using a speculum, and the key here is that speculums come in all different shapes and sizes. And so part of your self-advocacy might be to say to your provider, I do have pain. I understand if you want to do an internal exam, do you have a small speculum that you could use that could be more comfortable for me? And so we use a small speculum for a lot of people because we want to look to see the health of the vaginal tissues and the cervix. We will often also talk with our patients about doing a bimanual exam, which means inserting one or two fingers into the vagina and feeling with the top hand, the uterus and ovaries. We're trying to feel for pain, for masses, lumps, bumps, that kind of thing. That's part of the whole pelvic health exam. And then depending on your age and what's recommended, sometimes we'll be talking to you about cervical swabs, vaginal swabs, testing for the human papilloma virus, or doing a pap test. And those are all things that we would talk to our patients about. So these are some of the questions that physicians or nurse practitioners might be asking that are helping us start to think that this might be what's going on. And again, when I'm talking to patients, I'm thinking about genital symptoms, sexual symptoms, and urinary symptoms. And even if somebody isn't with a partner currently, that doesn't mean they're not having sexual activity. They could be using a toy, a vibrator, a dilator. And so I'm interested to know what the comfort is around that as well. And I want to talk a little bit about the tissue changes specifically, and then we're going to have some photos coming next. But when people are before menopause, when there's lots of hormones circulating around in the body, the tissue of the vulva, vagina, bladder is thick, it's pliable, stretchy. There's a lot of collagen, there's a lot of blood flow. There's fat in the vulva, the muscles of the pelvic floor and bladder neck are working well. And then as we come into a low estrogen state, which persists until the end of time, then we see tissue thinning, etc. Okay, so I'm here for my next medical photos, just as a heads up for everybody. But I wanted to show real photos of what this looks like so that people can start to think about their own anatomy, because the goal of these lecture series, above and everything else, is to empower you for your own health. So what I want to show here are some examples of different vulvas where what we can see is redness We see that the vulva opening is very narrow. We see that the small labia are quite small. We can see that the urethra or the bladder neck is front and center. In the first picture, it's red and very sort of irritated looking. And we can see in the other two photos that the bladder neck is very prominent. And so you could think in your mind how easy it could be for bacteria to climb up inside and cause an infection. We can see redness at sort of the 6 o'clock position of the vulva, what we call the vestibule. And for people who are sexually active, that's often where it hurts the most, right at that sort of midline position. And some people can get tears there or little fissures as well. Now, not all burning, pain, or bleeding is because of dryness. And on the next slide, I'm going to show you pictures of two other conditions that we're looking for also, which is why doing an exam is so important. So on the first slide, that's actually a picture of a vulvar cancer that can cause irritation, bleeding, pain, discharge. But all of the moisturizers and lubricants and vaginal hormones are not going to make that better. We have to look and examine people to make sure we know what we're managing. And the picture marked B is a skin condition called lichen sclerosis, which is actually quite common. You definitely know somebody who experiences this skin condition, and it can cause whitening, tissue thinning, pain, difficulty with intercourse, narrowing, but this is treated differently. So the point of me showing you these slides is because I want to encourage you to be empowered to ask your healthcare provider, do I need a physical exam? Are we certain that this is what we're dealing with? Especially if you've tried a treatment and it's not helping you, I really encourage you to request a physical examination if you feel like your symptoms aren't being well controlled. So I'm going to move in now to how do we treat this. And this is exciting for me because I want everybody who's listening to maybe come away with some ideas of things that they might talk to their healthcare providers about if they're having symptoms. So I mentioned already that hot flashes and night sweats and sleep disturbance often, not always, but often improves over time, whereas symptoms of GSM often just continue along and in some cases can become worse with time. And the important point in the second bullet is that if we're not recognizing and treating GSM, people can have permanent structural changes to the vulva and vagina that can be very difficult or in some cases impossible to reverse. And it's really devastating. Dr. Gustafson and I have both met these patients who have had symptoms for a really long time. It's taken a long time to get help. Perhaps they have too much pain to have, penetrative intercourse with their partner. They're looking for help and treatment, and it can be very, very difficult to help get them back to a point where they can be sexually active again with penetration. So the goals of treatment, of course, we want to help symptoms. We, of course, want to improve function of the genital tract and the bladder, and we want to improve quality of life. We also want to make sure that we can preserve people's ability to have exams in the future because we can get to a point where it can be very difficult to have an exam. And then if somebody has bleeding or pain in the future, it's very difficult to evaluate that. And so how do we treat people? We take a history, do a physical examination, and then think about that person's severity. And we talk to them about options for management. But there are a lot of different options, and that's, why it's a great time to be a person who's moving through this menopausal transition and why it's a great time to be a menopausal provider.
So Dr. Mills, I've got a question from a participant who says, I've got symptoms of GSM, but I'm a breast cancer survivor. And I'm really afraid about treatment because I've heard a lot about vaginal estrogen, but I'm not sure that's safe for me, and I'm not sure what else to do. And this person's like doesn't want to bring it up with their care provider because they're anxious about that. So you're probably going to move on to treatments, but how would you address this kind of question?
Yeah, first of all, I applaud you for being here and asking the question. I have a couple of thoughts. The first thought is, um, there are so many options that we can talk about for treatment, and for the vast majority of people, including people who have survived a breast cancer diagnosis, we have lots of options that are safe, including hormonal options that don't go systemically through your whole body. And that's really the focus of breast cancer treatment, is avoiding hormones that go systemically through the body. And so we have a lot of options. We also have non-hormonal options. And sometimes for my patients, I take the history, I do a physical exam to make sure I'm not missing something else. And then maybe we talk about some non hormonal options and start there. And then we work into the conversation around hormonal options, because there's actually a huge volume of scientific data to suggest that for the vast majority of people, including breast cancer survivors, that hormones can be safe. And I'm going to talk a bit more about that. But it's a great question, and one that is near and dear to my heart. So these are the non-hormonal things. So perhaps we're just even starting out there, for the listener who had asked the question. There are certain things that it can improve GSM symptoms, including quitting smoking, reducing caffeine. These both can be cause bladder issues, and quitting smoking can improve skin texture and tissue texture. Weight reduction is a recommendation, especially for incontinence, people who have issues with bladder health, and vulvar hygiene, which I have a whole slide on in a few minutes, and we'll go through that. Activity modifications, you see a recommendation there around regular sexual activity, self-stimulation using vibrators or dilators. That's encouraging blood flow to the area, to the vulvar organs, also to improve stretch, caliber of the vagina side to side, length of the vagina, sort of, on the long axis. And if you're not sure where to start with that, we think our pelvic floor physiotherapy colleagues are incredible. They are covered if you have extended health benefits, as if you needed to see a physiotherapist for your tennis elbow. These are specialized physiotherapists. The majority of them identify as female. They might do a physical exam to see how they can help, but they are amazing for bladder, bowel, constipation, sexual pain, GSM symptoms. And we really encourage people to see one of them. You don't need a referral from your physician. You can make a phone call and see a pelvic floor physiotherapist. Then we're talking about lubricant versus moisturizer. So lubricant is for penetration with a partner, with a toy, with a vibrator, etc. And so those are often water or silicone based. Some people will use a natural oil if that feels good for their skin. And then moisturizers are like putting moisturizer on your hands, or keeping your other skin healthy. We can use these even multiple times a day if people wish. A lot of them have hyaluronic acid, which my teenager daughter says I should be putting on my face. So there you go. But these can really help with lubricate with moisturization. And there's some pretty good data out there to suggest that if people use moisturizers enough, these studies were done in the breast cancer population, that people can really have good resolution of their symptoms. Topical lidocaine is on there for people who have significant sexual pain, and oftentimes we'll talk to our patients about that. But people have to use a condom with a male partner due to numbing.
So I know
Okay.
you weren't going to, you're not supposed to name any brands, but we do have a couple questions in the chat about the pH of a lubricant and a moisturizer and how important that is, and what specific brands of moisturizers you recommend.
I'm hesitant to recommend any specific brands, because I just find that it's a really individual decision. What I will tell you are things that I don't recommend. anything fancy. If it sparkles, if it numbs, if it has a fancy flavor, if it has a fancy color, if it has a perfume, a lot of those are really irritating to people who have a vulva or a vagina. So I would stay away from those, and I would really be choosing bland, uncolored, unsparkly products as your lubricant or your moisturizer. And a lot of people can get help with from their pharmacists by looking. All those are over the counter, which is great in terms of access, but they can be expensive because they're not covered by an extended health plan.
And I think for
Um,
moisturizer, we're generally recommending things with hyaluronic acid for vaginal
yeah,
moisturizers rather than things with other fancy chemicals in them.
that's right. I will tell my teenager that she was right about the hyaluronic acid. So here we're now talking about hormonal treatments for GSM. And, Dr. Gustafson really wanted me to make the point that these are first line treatments. We don't ask patients to try moisturizers for 6 months before we talk to them about these hormonal options. A lot of people might try them on their own or make different decisions, but we're offering these up at the same visit that we're talking to people about their symptoms. We're lucky in Canada that we have 7 different options that are Health Canada approved. There are 8 dosing options. And a lot of these are actually covered by extended health benefits. And we're really excited to see what the provincial government does in 2026 in British Columbia about funding menopausal treatments for people. So we're really looking with interest to that. I will not give you specific names, but there are 2 different creams that can be inserted or applied to the vulva. There are 2 different types of inserts. One is a little pill like suppository, one is a soft gel. These are inserted into the vagina, usually twice a week. There's an estrogen containing ring that's inserted into the vagina and changed every 3 weeks. There's actually an oral pill taken by mouth every day that is targeting GSM symptoms. And that's pretty fancy the way it works, where it is really active on tissues in the vulva, vagina, bladder, but not active other places like the breast, for example, or the uterus. So that's a pretty neat option. It's one of the more expensive ones, but it's an interesting option. And then we have one other option, which is a daily vaginal suppository. And it's actually made out of a precursor hormone that is converted in the cells to estrogens and androgens, and also helps with the symptoms of GSM. The reason I put these all up here is because I don't want people to feel discouraged if their provider gave them one thing to try and they felt it didn't work. There are so many different options, and it's great to be empowered. And if your provider has given you a cream and said, "That's it, that's all there is," then you can say, "No, I heard a lecture from BC Women's, and she said that there were 7 options in Canada. Can I try something else?" Because not everything works for everybody on the first try. What I want to talk about is safety, because just today I spoke to a patient who I had prescribed a local hormone for her GSM. And she said, I opened up the big package in the box and it had a lot of scary words in it. And so I didn't feel comfortable trying it. And what I want you to hear is that we call that a black box warning, and it's in all of those preparations in the packaging. But that is from systemic hormone data, hormones that we give people that go to all the cells in their body. And the hormonal treatments that I just put up on that page really are acting locally. And we have great data to say that these do not make your chance of breast cancer worse. They don't increase a risk of stroke. They don't increase a risk of other cancers or having a heart attack or blood clot. So I usually say to people, you're going to open up the big package and it's going to look really scary, but those aren't actually applying to this medication. And there have been a lot of effort from Canadian organizations, from American organizations to say to Health Canada and the FDA, can we change this labeling so that we're not scaring patients away from using this very safe extremely low dose non-systemic medication. And hopefully we'll see this in our practice lifetimes, right, Dr. Gustafson? It's got to happen.
Something good's got to happen there.
So we heard the question from the person who had survived a breast cancer, and I just want to reiterate that you've heard that there are some non-hormonal things that can help, and a lot of people who have survived a breast cancer might feel most comfortable starting out with one of those. But we have more and more data supporting the use of low-dose, local, non-systemic hormones in people who have survived a breast cancer. This is our current Canadian guideline, which I have to admit is fabulous, only because I was one of the authors on it. We are revamping it, but it will continue to say that vaginal hormones can be offered to women with a history of breast cancer. There's a caveat there around women on aromatase inhibitors, but even those women taking medications like letrozole or anastrozole, we have more and more information coming to suggest that it can be safe to take low dose local hormones for treatment of GSM. So, we're learning more and more all the time. These are some vulvar hygiene tips that I just want to share because a lot of people are really well-meaning, but they may be doing things that can be making their burning, itching, discharge worse. The biggest things we see as gynecologists are people who are using pads all the time when they don't need to, or people who are putting agents against the vulva or vagina that are irritating. And this is, scented bubble baths, colored bath oils, perfumed oils. I see people who are douching or inserting, fluid inside the vagina with really strong chemicals to try to clean the area. And that is not helpful. That's going to make the irritation and discharge worse. And then when we're moisturizing, as it says below there, we're using bland, unscented moisturizers, hyaluronic acid, as we mentioned. And when people do these vulvar hygiene tips, they can actually help a lot of their symptoms just right off the bat. Another big culprit I see a lot actually are heavily scented dryer sheets and fabric softeners. People can find vulvar irritation. So I want to talk briefly about being a self-advocate because we've already seen the data that shows that maybe we as providers aren't asking as much as we should, and thus our patients are not telling us about their symptoms. So I've borrowed this from the Menopause Foundation of Canada website, and I really encourage you to check that organization out. They are a nonprofit, incredible advocacy group, and they encourage all people to track their symptoms and document them, to do some learning about their symptoms online or even sharing with friends. Have you gone through this? Have you had any treatment? And then preparing for the visit with your healthcare provider. These are my symptoms. This is how long it's been going on. I've learned a little bit about this. I'm wondering if I might be a candidate for treatment X, Y, or Z. And I think people can feel really empowered when they have a bit of a plan when they're going in to have a successful conversation with their healthcare provider. So in summary, because I want to leave some time to answer the questions that have been sent in or the questions that are showing up in the chat, we have learned that genitourinary syndrome of menopause is really common. It's going to affect a lot, if not the majority of people going through menopause, and can have genital, sexual, and urinary or bladder symptoms and signs associated with it. People going through menopause absolutely deserve help with these symptoms, which can be lifelong once they start recognizing them. Treatments, for GSM are safe, and they can be non-hormonal or hormonal, but in the case of hormonal treatments, they are non-systemic and can even be appropriate for people who have had a breast cancer or other hormone-sensitive cancer. Women have so many different treatment options to choose from, but I want you to remember that there are 7 Health Canada approved options for this. And so if something hasn't worked for you, if you've given it a good try, then please return to your healthcare provider and say, I know that there are other treatment options out there. Can you help me try a different one? It is true that some women may need to be self-advocates for their treatment. And I really hope that with further medical education, we'll get to a point where we're really proactively asking our patients about symptoms. And I want to remind people that the use of vaginal hormones is extremely safe, and there is no maximum length. So you can be on your vaginal hormones throughout your life. And when I was training in the menopause unit in Toronto, I met women who had been on vaginal estrogen for 50 years. So these are safe and they are efficacious. And I really encourage people to have the conversation. These are some patient resources that can be excellent. There are a few from our Canadian agencies, and then I've also included a handout from from the Menopause Society. These are written for patients to read. These are not doctor level language. These are patient centered handouts. And so, if you're having a challenging time getting help, maybe you can take a look at one of these, have a read, and maybe even bring it with you to your health appointment and say, I've read about this. Could I have this? Are some of these treatment options available for me? And I encourage everybody to check out the Menopause Foundation of Canada. Something that is unique to their organization is they have a whole section on how to support a person in your life who's going through menopause, because we had huge requests from partners of patients to say, we want to hear more about this. How can I support my wife, partner, etc.? So with that, I'm happy to answer any further questions from Dr. Gustafson and the people who have joined today. And I'm really honored to be invited by BC Women's to give this talk. Thank you so much for your attention.
Thank you so much, Dr. Mills, for that fabulous presentation. I hope everybody learned a lot. I learned some things too. We've got a few questions that were sent to us in advance. And we also have a couple questions that came in the chat. And we have one question that came in just looking for a little bit of clarification on the difference between systemic and local estrogen. So the question was specifically, are the patches considered systemic? So, I think, go ahead. And then
Sure. Really important question and really important distinction. So, the slide I showed on the different vaginal hormones, those are hormones that are just acting locally, just at the vulva, vagina, bladder. They're not, attaching to estrogen receptors in our brain or estrogen receptors in our gut, which, by the way, we have. Whereas systemic hormones in Canada have Health Canada approval delivered by oral pill, by a skin patch, or by a gel. There's only 3 ways to have a Health Canada approved estrogen that are systemic. And those hormones are going to all the cells in the body and are treating hot flashes, night sweats, sleep disturbance, mood, etc. So that's a really important point. And the two have very different safety profiles.
And I would just, add that some people are using compounded preparations that may be prepared by an alternative care provider, and that might be applied to the labia or the vulva. And in that case, it's much harder for us to distinguish between things that are giving systemic levels of treatment and things that are giving local estrogen. Which is part of the reason that we recommend Health Canada approved products all the time. But thanks for that, Dr. Mills. I have a question here presented in advance. This patient was pushed into menopause as a result of chemo rather than spontaneous menopause. And how will that affect their body?
Great question. And I see a lot of these patients under the setting of oncology associated menopause from BC Cancer. And first of all, we see young people who go through menopause 20, 25 years earlier than they otherwise would have. And we know that if somebody enters menopause under age 45, that there's a strong recommendation to have systemic pill patch gel estrogen and hormone therapy in order to improve your bone, heart, brain health and overall longevity. And we know that people who have menopause because of chemotherapy, surgery, radiation, or other medicines, they can experience a more sudden and, in some cases, more severe menopause. So we really are looking for those people to help them because they don't gently drift in over a period of 8 years. It's sudden and dramatic, and these people can be extremely symptomatic.
Thank you. And then another question we got in advance was, have you looked into, or I guess, is there much research on how having a disability, particularly like paralysis, spinal cord injury, being wheelchair bound might add to the situation or make things different or worse?
Great question. And I know that there's some really exciting research, even in British Columbia, in some of the research units about this question. When I meet a patient who perhaps has had a spinal cord injury, there are some unique considerations there. Sometimes the sensations in their body may be interpreted differently by their brain or spinal cord. I've definitely met patients who we had a really challenging time getting their hot flashes and night sweats under control in the context of a spinal cord injury. We're also thinking about people who might be using a wheelchair as a mobility aid, and maybe changing some of our treatment options if people are less mobile or less ambulatory. So there's a lot of work and research to be done, but I think it highlights that we look at people as individuals and talk to people about what their symptoms are like, what their experience is like, and everybody deserves a history and physical examination, regardless of your mobility.
Thanks, Dr. Mills. And then there's another question about, how does pregnancy affect genital urinary function? And I think this question is specifically genital urinary function during menopause. But I think there's also a topic related to post-pregnancy genital urinary function in there that we could work on as well. So I'll let you.
Yeah, I think that's great. I'm not really aware that pregnancy itself has any specific impact on people's then experience of GSM in the future. Um, but certainly, people who are pregnant and have birthed and are now in the postpartum period can have GSM like symptoms. And that's because if people are breast or chest feeding postpartum, their hormone levels fall off. It's nature's way of providing some contraception so that we aren't pregnant again right away. And a lot of people can have significant dryness, pain, itching after birth as a result of lower hormone levels. And that's even compounded if people have had a significant tear or repair at their birth. And so sometimes we will use some of these hormones in a safe way locally to help people who have birthed and who are having symptoms.
And I remember learning that vaginal delivery is somewhat protective against later GSM, but I don't know the primary source on that.
It's an interesting one. I think anecdotally we can see that people who haven't birthed or who have had a cesarean birth perhaps can have a narrow caliber as they're going through GSM, but certainly people can have pain in many different situations.
There's a number of questions in the chat about the overlap between lichen sclerosis and vaginal atrophy and whether vaginal estrogen is indicated. Do you want to take a stab at that briefly?
Great question. And I think the first thing is that, again, history, physical exam. Do people need a tissue biopsy to confirm a diagnosis, to rule in or rule out something serious? A lot of us treat lichen sclerosis often with a topical steroid ointment, which is the standard of care. But lichen sclerosis and the people who have that skin condition can have a lot of benefit from vaginal hormones as well. Classically, we see lichen sclerosis in people usually, but not always, who are postmenopause. And so we'll often be using a combination approach with local hormones and a steroid as well.
And I've actually received this question from a physician in the last week, so I'm happy to see it from the general audience, which is it ever too late? Are you too old to use vaginal estrogen? because I actually got a 65-year-old referred to me with multiple urinary tract infections where the primary care provider didn't want to prescribe vaginal estrogen because of their age. So I think this will be an easy one, but I'll flip it to you.
I think this is really important. And where the confusion might lie is that when we're talking about systemic hormones, pill, patch, gel, all of our guidelines agree that we aren't really supposed to prescribe that to people who are older than age 60 or further than 10 years from their final menstrual period. So perhaps the physician in question is thinking about that age 60 from a systemic hormone point of view, but there is no minimum or maximum age to use vaginal hormones. And I have women in my practice who are in their 90s, and I have one person who is 100, and they use vaginal hormones because they're safe, remembering no increased risk of any cancers, stroke, clot, or heart attack.
And I would argue that some of the very older patients are the ones who are benefiting the most from it, particularly in reducing bladder and recurrent bladder infections. So that's wonderful.
Absolutely.
I think there's one more question. I'm going to lump a couple together. The
Sure.
question is, well, since GSM is not per se a diagnosis, it's a collection of things, shouldn't we have a checklist that patients can take to their provider in order to help them bring up the issue? And I think this is another question about patient advocacy. What's the best way for me to advocate for myself?
So, first of all, I think any tool or checklist or memory aid that's going to help a person to get their point across with their healthcare provider is a great thing. And this might be something that you pose to the Menopause Foundation of Canada. They've built a menopause symptom tracker. Maybe next for them is a nationally endorsed GSM checklist. I think it's an excellent idea. What's interesting is that some people tick all the boxes and some people just have recurrent UTI or just have, vulvar irritation. So the experience can be really diverse, which is why it's important to know all of the different ways that people can experience this and mostly that there's help.
That's wonderful. And also to let people know you don't have to have lots of symptoms in order for them to be valid. You can just have one symptom and that's enough. Like you don't need to check all the
Exactly.
boxes.
Exactly.
Dr. Mills, it's been fabulous having you here tonight, and thank you for sharing your expertise with us. For anybody who didn't get their questions answered, just be reassured that we do hang on to your questions and we use them to help guide our future presentations. There's also a QR code on the screen somewhere here that you can click and give us an evaluation, and that will help guide our future seminars. I look forward to seeing you all here again at the end of November. I believe it's November 25th, the Tuesday, for Dr. Tara Sedlak, who's going to talk about menopause in your heart. So we know our hearts are very important. I believe in January, we're going to have Dr. Zentner talking about menopause and weight, since January is the season for that. So we really appreciate you attending. We appreciate all the little hearts floating up on the screen. Thanks again to our sponsors, and thanks again to Dr. Mills. And I hope everybody has a fabulous evening. Thank you very much.